We are here with Dr. Shah. We want to ask you about some details about which is the preferred patient to go with TMT option of treatment.
Got it. So you're asking for patients who have muscle-invasive bladder cancer.
Yeah,
How do we determine who would be suitable for trimodality therapy?
exactly.
And for whom should we take the more standard route of radical cystectomy?
Yeah, for sure.
Yeah, it's a good question because we know that radical cystectomy is difficult for patients, and we know that it's also curative for most patients. So trying to figure out who are the patients that we can offer trimodality therapy to and who are the ones we shouldn't. We spend a lot of time thinking about this. And the way that I do it in my practice, when someone comes in with a new diagnosis of muscle-invasive bladder cancer, I have the full conversation with them around the implications of this disease, what this diagnosis means for them. We talk about the treatment options. We say there's surgery, radical cystectomy. We talk about trimodality therapy. We talk about neoadyuvant chemotherapy, or now more drug antibody chemoimmunotherapy, etc. And I will have the honest conversation with a lot of patients that I imagine that your sort of best case scenario would be to be cured of your cancer and to keep your bladder. Is that accurate? Some patients will say, get my bladder out no matter what, it's too stressful, please take it out. Or they have a lot of bladder symptoms because they have an enlarged prostate or they have incontinence already. They have reasons where keeping their bladder doesn't necessarily sound like a good idea. For those patients, we don't really spend too much time offering TMT. Okay. But if the patient has good bladder function and wants to try to keep it and would like curative intent therapy, we'll say, you know what we can do is we can try this other possibility. And very often I will do another TURBT myself before we go down that route of deciding on TMT or not, in the sense that I don't know what's left behind. If the initial resection was done by a different urologist on the outside, I can't quite verify how much disease is left or not. And I believe in the principle of maximal TURBT or visibly complete TURBT. So the best way to do it is to do a TURBT myself. So I'll do the TURBT, and if we can get reasonable control, get all the disease out, etc., then I'll talk with the patient and say, we know that people who have muscle-invasive bladder cancer have a higher rate of occult lymph node positivity than we would like. We believe strongly in systemic therapy before definitive therapy. And I'll send these patients to my medical oncologist to talk about neoadjuvant chemotherapy or immunotherapy or combination. And at the same time, I'll say, if you would like to try keeping your bladder, there's no guarantee that we can do that. But if you would like to try that, what we can do is have you start the systemic therapy, the neoadjuvant systemic therapy, whatever it'll be, and toward the end of that, so let's say after cycle 3, if they're going to get 4 cycles of chemotherapy or immunotherapy, after cycle 3, we'll go back to the operating room, do another TURBT. Okay. If at that TURBT there's no residual disease between the combination of the initial TUR and the systemic therapy, if it looks like we've got good control in the bladder, we'll say, go ahead and finish your systemic therapy, and we feel comfortable recommending you for trimodality therapy, for chemoradiation, where they'll get concurrent chemo and radiation at that point. If that repeat TURBT toward the end of the systemic therapy shows there's still residual disease or new disease growing, then I feel much more uncomfortable around recommending trimodality therapy, and we'll say, let's get your bladder out.
And in those patients that receive chemoradiation therapy, what concerns are related to the complications of performing a savage cystectomy?
Yeah, there used to be this notion, and maybe in a lot of circles there still is, that doing a cystectomy after someone has had radiation is very difficult. And that's not necessarily true. I think if you are an experienced bladder removal surgeon, if you've done a lot of cystectomies, having had prior radiation does not actually increase the complexity of the operation very much.
Okay, and those are clinical variables that you try to put in on the real world patient, right? Mm-hmm. So, do you evaluate nutritional status, age, social status, economic status in preferring one therapy or another or the other one?
Yes and no. And what I mean by that is we consider those factors, but not in a particularly quantifiable or scientific way. It's more, well, you know, this patient seems really decrepit. They seem super weak. Their nutritional status seems really poor. I'm worried about their ability to heal after surgery. But it's not like we have a scoring system where we'll give scores for nutritional status, for social support, for socioeconomic status. You know, we don't, I actually think this is where AI will be able to help us because there is so much data, so much information. We as humans in our limited capacities don't know how to put it all together. But AI can have a much more global view of these things. So I'm excited for the future for what AI can do for bladder cancer care.
Okay, and are you implementing in nowadays the genomic information? I mean, like ctDNA in those patients with muscle-invasive cancer and perhaps those that are locally advanced N2, N3 that perhaps do some downstaging in order to be candidates to surgery. Do you feel comfortable using it in which time? And
yeah, I would say that we are at a point where we are learning how to use it most effectively. I wouldn't say we're at a point where we've got it figured out and we have a perfect protocol. I'd say many academic centers in the US and internationally are still grappling with what's the best way to use these data. The data that's coming out from the research studies shows that there is meaningful information to things like circulating tumor DNA, genomic tests, et cetera. We haven't quite figured out what is the best thing for everyone to do all the time with these things. We're using it very often sort of as a marker of minimal residual disease. So after someone had systemic therapy, we'll see what happened to their markers. Is their ctDNA very low? And if it's 0, then we feel very comfortable saying, let's not do anything right now, or let's do something less aggressive than surgery, et cetera. But we don't have ironed out protocols yet.
Okay. And you start to integrate those genomic information with the imaging. Actually, we discussed a little bit about the radiologists reading all those studies and the BRATs and the neo-BRATs. What are your highlights about that readings? Do you feel comfortable with that? That's enough to take decisions?
I think you have to have appropriately trained radiologists who are specifically focused and specialized, number one, on genitourinary radiology, and ideally have a lot of experience looking at bladder MRIs, because I do think that there is a nuance to reading those. Someone made a comment during our panel discussion that there's a lot of variability in what a radiologist will call and then what the final pathology will see. And I think that's because you do need to have an experienced radiologist. I'm a fan of MR bladder testing. I think we just have to figure out what are the best places for us to be using it. I think, as we discussed previously, doing an MR of the bladder after TURBT is really not that helpful a lot of times because there's widespread inflammation in there. But doing it on someone who's newly diagnosed with a bladder mass, where there hasn't been any intervention inside, I think can be super helpful.
Okay, and in special imaging like PET-CT, do you see any use in all the in the patients with muscle-invasive bladder cancer?
Yeah. I know that our medical oncologists very much like the information from PET-CTs, as do I. And I see MR bladder and PET-CT as two different reasons, two different things we're looking for. The MR bladder, we're mainly looking for local extent of disease. How far out of the bladder has this cancer grown? For the PET-CTs, we're trying to see what is the distant spread of this disease. Are there any lymph nodes that are involved? Are there any hot spots in the lungs, liver, elsewhere that we should be concerned about?
Okay.
Because that totally changes the game for how we manage urothelial cancer. If someone has a PET-CT that lights up somewhere, then I'm not that useful as a local surgeon. Okay.
Thank you so much, Dr. J. It's a pleasure to have you here in Colombia. We hope see you next time here.
Thank you, Dr. Martin. Pleasure chatting with you.
Totally.